Afternoon to some and good evening to others. Hello,
Yes.
everyone. Welcome, dear friends, neighbors, supporters of the Gray Panthers. Welcome back to our Transformation Tuesday series after our winter break. I trust everyone is rested and excited to hear about palliative care from our distinguished panelists, Dr. Catherine Pettis, who's joining us from Spain, and Miriam Rabner, who's based in New York City. So, as you know, I'm Michelle Arnaud, and on behalf of the board, I want to thank you all for your support of the Gray Panthers movement, which was founded in 1970 by Maggie Kuhn, our fearless leader who famously told us to speak up, although our voices may shake. We do our best to live up to the mission that was set up by Maggie over 50 years ago to combat ageism, which is pervasive in society, particularly in healthcare, and to promote intergenerational contact, which is what we're striving to do with our series. Today and every month, our intention is to provide a safe space to change the narrative for how ageism impacts our daily life. And our goal is to make a positive difference, thanks to your help and participation. Since 2021, we've convened on the last Tuesday of the month. All of our webinars are recorded, and you can find them free of charge on our website, gpnyc.org, posted by our multi-talented tech manager, Emily Trask. So please feel free to listen to any of our past webinars. I'm going to introduce our distinguished presenters, some brief background information. Dr. Catherine Pettis is Senior Advocacy and Partnerships Director for the International Association for Hospice and Palliative Care. She holds a PhD in political theory from Columbia and a master's in health law and policy from the University of California, San Diego. She has addressed the United Nations, among other institutions, in her global advocacy work to improve the availability of palliative care and the rational use of essential palliative care medicines as components of the right to health. Her focus is equitable inclusion of vulnerable populations, such as frail older persons, prisoners, persons living with disabilities, Indigenous persons, and those affected by humanitarian emergencies. As I said before, she's a resident of Spain. She's a Benedictine oblate and grandmother of 3. Miriam Rabner, our second presenter, is a graduate of Yeshiva University's Stern College for Women and the City University Graduate Center. She was born and raised in Switzerland in a multilingual Holocaust survivor family. Miriam is a resident of Riverdale and has been a community liaison for MJHS Hospice and Palliative Care in Manhattan and the Bronx for nearly 20 years. So before we begin our presentation, our Vice President, Carrie Lil-Jadal, would like to say a few words about how we thought of doing this program. So, Carrie.
Thanks everyone for joining us today. Like Michelle said, we took a break for a few months and we're really happy to be back. Palliative care has always been really important to me. As most of you who know me know that, I'm in this field because of my son. And there's a lot of, we started out with the medical world is in pediatrics, and people don't look at even there, what do you need to do to improve somebody's quality of life? Their palliative care is not a hospice program, and that's the first issue that everybody has, and they want to look at somebody's age. At one point somebody's like, oh, but he's only 14 years old. Yeah, he might only have been 14, but he needed the care for what he needs. And people need to understand that the most important thing that can come out of a good palliative care program is quality of life. Quantity, nobody knows what anybody's quantity is, but we all know we want a quality of life, and that works whether we're sick, we're aging, whatever it is, but everybody should have that option. And there is one of my very favorite people, High Tone. Sorry, I just got sidetracked. So we're really glad you all joined us today. this is such an important topic. And even if you learn one thing and help one other person to get the quality of life they need or deserve, I would be forever grateful.
Thanks, Carrie. And now we'll begin the program with Dr. Catherine Pettis. So, Catherine, over to you.
Thank you. Give me a minute to share my slides, please. Everyone see that?
Yeah.
Okay, let me see if I can shrink all the people, because otherwise I can't see my notes. There, that's better. So, thank you, Michelle, Jack, Carrie, Grey Panthers, and Miriam. I'm really honored to present to you tonight for the International Association for Hospice and Palliative Care on the situation of older persons globally as regards palliative care development. So that's our logo, that's your logo, and this QR code has a link to our website if you would like to take a look at some of the work we do. Otherwise, it's just ihpc.org. My work focuses mostly on advocacy, so that's what I'm going to talk about. But first, the organization of my presentation is I'm going to talk basically about, just for one slide, about IHPC, who we are, what we do, the global situation, the conceptual framework and definitions, barriers to availability, policy deficits, and recommendations. So the International Association for Hospice and Palliative Care is a global membership organization with more than 1,200 members in 153 countries, which we see when we click on the red dot on our interactive map on our website. Our vision is a world free from health-related suffering, and our mission is to serve as a global platform to inspire, inform, and empower individuals, governments, and organizations to increase access to and optimize the practice of palliative care. We're in official relations with the World Health Organization and in consultative status with the UN Economic and Social Council, where we advocate for what's called a global normative framework for palliative care. That's a legal framework. So that's basically who we are. And this is a consensus definition that IHPC worked out with hundreds of practitioners around the world of palliative care, just so we're all on the same page. I'm sharing this global definition, which is based on the original WHO definition, which is about 20 years old. But this one was refined through a really participatory process that included practitioners, patients, and donors, including from low and middle income countries. So we define palliative care as the active, holistic care of individuals across all ages. So obviously that includes from neonates to fragile elderly persons with serious health-related suffering, so not just cancer, due to severe illness, and especially those near the end of life. So the especially those means it's not just for the end of life, and it's not just for cancer, as I said. And as Carrie was saying, this is part of our definition. It aims to improve the quality of life of patients, their families, and very important, the caregivers, who are often the invisible helpers, usually women and often older women. And the definition has a lot of components, just as the WHO definition does, but I just picked out a couple to tell you that palliative care involves the comprehensive assessment and management of physical issues, including pain and other distressing symptoms. That's really major, but also psychological and spiritual distress and social needs, which means it's interdisciplinary, multidisciplinary is another word. It provides support to help patients live as fully as possible until death by facilitating effective communication and helping them and their families determine goals of care. So it's what makes palliative care so distinctive is that it's interdisciplinary, because with regard to other medical disciplines, I think it's the only medical discipline that includes spiritual distress and social needs. And it's also, of course, if you go to our website at some point and review the definition, it says that it accepts natural death, and it's distinct. The definition doesn't say it's distinctive from euthanasia. I'm just saying that because some people confuse palliative care with euthanasia, with assisted dying, and it's distinct from euthanasia because it accepts natural death as part of life. And it's biophilic rather than necrophilic in that sense. It really supports quality of life until death for everybody, not just the patient. So this map shows the levels of service development per 100,000 patients in all the different countries. With the dark blue dots, I'm not sure how well you see that, but you can't actually see the dark blue dot on the US, which is here. The US has a dark blue dot, Australia has a dark blue dot, Canada has a dark blue dot. And they have more integrated services available for more people. Obviously, you get the idea. Whereas the smaller and lighter dots, which you'll see all over the world, have much sparser services, if any at all. And you can also see then from this that the service development in palliative care follows the Human Development Index, which is actually no surprise. And Northern Europe especially does very well here with the high-income countries. So that's a very quick snapshot of global palliative care development. This is another map that shows the global unmet need for opioid-based medications, which was done by the Lancet Global Commission on Palliative Care and Pain Relief in 2018. And it shows the global inequity in access to morphine-based medicines and opioid-based medicines, sorry. So while countries such as, continents such as North America, I was going to say countries such as the US, Australia, and Canada receive upwards of 40,000 milligrams of what are called distributed opioid morphine equivalent. Sorry for the acronym, but that's DOME. So just remember 40,000 per patient per year in need of palliative care. And this is all tracked by the International Narcotics Control Board. Patients in countries such as Nigeria and Haiti receive less than 1 milligram per population. So it's 40,000 to 1. And that's why you have these bloated continents that have too much excessive consumption, because that's what this is based on, consumption, versus these shrunken continents and regions which are way underserved in terms of pain medicine. And the benchmark region of the world is, as I said with the other slide, Northern Europe, where it's considered that it's a balanced availability which receives enough for medical needs while preventing harmful non-medical use, as the US has and is still experiencing. Although, as most of you know, I'm sure, the US opioid overdose crisis is fueled by fentanyl and illicitly produced medicines. It doesn't come from the medical supply chain, but the misconceptions around that too are fueling this crisis in countries with the stick countries, which don't have enough. And I'll talk about that in a minute. But my take on this really is that the 86% global unavailability of palliative care, according to the World Health Organization, is actually ageism writ large, because the WHO tells us that each year, An estimated 56.8 million people, including 25.7 million in the last year of life, it's an enormous number of people, you lose sight of the individual, are in need of palliative care. And they say also worldwide, only about 14% of people who need it currently receive it. So obviously you do the math, 86% of the world doesn't get it. And that is particularly egregious given the world population, which is age 60 and over, is rising like this by region in terms of local population. And although in many ways that's a win for quote unquote modern civilization, that 86% of the global population with no access to palliative care will only increase, the need will only increase to God help us, 87, 88% to 90, since this steep rise in population and life expectancy is accompanied by a rise in non-communicable or chronic diseases. So let's forget another pandemic. These are non-communicable or chronic diseases such as cancer, dementia, heart disease, which are a source of a great deal of the serious health-related suffering that palliative care can alleviate. So the need to integrate palliative care into health workforces all over the world is urgent. That's what I advocate for. Or this preventable suffering, because it's entirely preventable, will increase with this population increase. So the system-level deficits that persist, although the WHO calls palliative care a global public good, that's UN speak, but it's a global public good in their language, it comes from a lack of policy attention and spending on long-term care, which is UN speak again for palliative care is included in that. And you can see that the US is here on this chart of OECD countries. This is a new chart that was just produced on long-term care spending, with Greece at the smallest of the OECD countries and Sweden at the largest. The US is in the middle, and palliative care all over the world is largely provided by charitably funded, faith-based organizations and private insurance or out-of-pocket catastrophic health spending for many people. So the health workforce is not properly trained in palliative care, and there are way too few geriatricians and palliative care practitioners. So with all these system-level deficits, it's very hard to see how we're going to meet global need. And I want to get behind those policy deficits and talk about the original sin underlying social ageism in healthcare, which I think of as the social and existential death that older people undergo in health systems at the social level. And it makes them invisible, us, I should say, invisible in the health system. And you combine that with what's called opioid phobia. It's a really toxic combination that's fueled by death anxiety, very widespread secularism in the global health community that tends to marginalize any kind of transcendental perspective. And the global health narrative itself, which focuses on explicitly reducing preventable mortality, that's a metric, preventable mortality, and increasing healthy lifespans, all of which are great. I'm not debating that. But that narrative must be expanded to include mortality that's not preventable, which is obviously 100% eventually for all of us, and attention to lifespans that are not healthy in a traditionally biomedical way, but can also be sources of joy and meaning for those on their last journey, as I've witnessed myself as a hospice volunteer. So very briefly, I'm going to talk about what's called the global normative framework that supports palliative care practice in all countries of the world that subscribe to a rule-based order. And the fact that governments don't implement that framework, which exists now, is the space where advocacy is needed at the national level. And that's what we support at my organization. So very briefly, the independent expert on the rights of older persons, who in 2015 was Rosa Kornfeld-Mate, said in one of her many reports to the Human Rights Council that states should ensure the availability and accessibility of palliative care for older persons in need, particularly those who suffer from life-threatening or life-limiting illness. Training and adequate and affordable medication and therapeutic measures should be provided in public and private care settings. And because she's an independent expert from the UN, this statement applies universally to all countries in the world and all people, and it has the authority of the Human Rights Council. Then we had the Human Rights Council resolution itself, which was subscribed to by all the countries that are members of the Human Rights Council. There was a resolution 48.3 about, I think it was 3 years ago, on older persons. There were actually 5 total mentions of palliative care, which is just amazing because most of the resolutions completely forget about palliative care, and we have to nag them to include it. But this came from a lot of the work we did in Geneva with the NGO Committee on Aging, where I was the secretary for a few years. And so now that resolution encourages all states to take measures to combat ageism and eliminate age discrimination and to protect human rights of older person. And this means that there's a lot of text in the middle, and to provide long-term support services and palliative care services. So this was the operational paragraph. There were lots of preliminary paragraphs in the preamble that talked about palliative care too, but this was the operational one that encourages states to include it. And then there's the Inter-American Convention, Article 6, which says that states parties should take steps to include that palliative care is included, and that fear of death of the terminally ill should be taken care of and addressed in order to prevent unnecessary suffering and futile, and useless procedures in accordance with the right of older persons to informed consent. So informed consent is very important for palliative care, and it really points to the need for advanced care planning, especially around patients with dementia, and supported decision-making for patients with dementia, but that's a whole nother webinar. So the next thing I'm going to talk about is how we're going to overcome this ageism, death phobia, and the service deficits I've pointed to. And I'm going to share a few thoughts based on my experience of hope and the years of work in this field, because hope is really a lethal weapon in terms of being able to accomplish these things. If we lose hope, then we're not going to be able to do very much. And one of the things that I think is very hopeful is the compassionate communities movement, which is taking root in all these different countries. It's just seeds at the moment. There's a global palliative care organization, Public Health Palliative Care International, one of our counterparts. And the compassionate communities movement is one response to the deficits we've reviewed. And the 95% rule here is that 95% of the time that anyone is dying or caregiving or grieving is spent outside the formal episodes of professional services, meaning only 5% is really spent in professional services during that period. And it's the responsibility of communities now to communities of all stripes, so whatever kinds of communities, to address the support needs of that 95% of the time. And in Western societies, death has been increasingly outsourced and medicalized, and crucial knowledge and skills at the community level, which were taken for granted before, have steadily declined. as a result of that medicalization of death. But compassionate communities support the idea of spreading a concept known as death literacy, which is practical know-how about what to do and where to find support at the end of life in that context. Most compassionate communities on that map are community-owned. Most people are volunteers. They go into schools. There are compassionate universities, grade schools, faith communities. And there's actually one compassionate country now, which is Costa Rica. And they make all those institutions, communities, faith communities, schools, etc., aware of the fact that they can help people in their communities. So that is one definite hopeful sign. It's really active in India. In South India, in Kerala, was where it spread up. This is in actually West Bengal. Elders Day Out in Koshish Hospice. It's just one example of the way India is leading this movement, but it's taking root all over the world, as I showed you. And the caption on these photographs, which came up on social media the other day, were Elders Day Out. And it says, the rural elderly who are otherwise delegated to menial tasks, like doing household chores or looking after the grandchildren, or worse, left alone, neglected to fend for themselves, deserve a day out once in a while. The rural elderly from the villages of West Bengal were invited to Koshish, the hospice, to spend time. We utilized this opportunity to conduct a basic medical checkup and blood sugar screening, which is why he calls it preventive palliation. He says they arrived by an electric auto rickshaw that we had hired for transportation. Blankets were distributed, and they were treated to a hot lunch with jalebis for dessert. They spent time loitering in the hospice campus, spending time with on the banks of the adjacent river, and chilling out in the warm winter sunlight and joking among themselves. So this is an example of one compassionate community project. There are many. So policy recommendations include developing ways to bolster home care, primary care, and to make geriatrics more attractive to potential professionals. Examples include establishing financial incentives available for educational purposes, such as loan forgiveness, scholarships, graduate school payments, etc. Or at the professional level, payers have to have incentives for enhancing reimbursement for clinical services delivered to older adults by professionals who have some kind of certification or specialize in geriatrics. And they have to work on recruiting and retaining direct care workers by increasing wages, providing more training, and incorporating them into models of care. So they're not just isolated and not trained like so many caregivers and not paid. And of course, there's the problem of the brain drain from the developing and middle income countries, which is, of course, they're attracted to work for higher salaries and better quality of life in the richer countries. But of course, that's draining the need in the countries that really need it, where palliative care has to be developed. So that's one problem WHO is trying to tackle. One last story of Josephine from Hospice Africa, Uganda, that was posted the other day. Hospice Africa is a charitably run hospice in Kampala, where I've spent a lot of time, that also receives its morphine from the state. And the team from Hospice Uganda met Josephine during an outreach visit to Namuwango's slum outside Kampala with an estimated 50,000 people who are packed together in dire poverty and horrendous conditions. Families share very small shelters with no electricity or running water. There are open sewers everywhere with small kids running around, barefoot and half-clothed, many clearly suffering from malnutrition. But, and I've seen this in Kampala, Nairobi, Bogota, all over, they have community volunteers who alert the teams to patients who might have palliative care needs. And so they were led to Josephine's shelter. She's an incredible woman, according to the report I got, who's 100. But apart from being blind, she said, Josephine seems to be in good health. And a family member who'd been caring for her had suddenly left some days previously. And one of her granddaughters had just arrived with her own child from outside Kampala to give her support. So my friend said, I'm in awe of the clinical team and their compassion for all. And this is the kind of palliative care that goes on in very low resource settings. It's still there and it's still really awe-inspiring. So challenges for global and US palliative care development. This is a really big one that I'm very concerned about, which is called financialization of healthcare, which is also called corporate capture and deserves a webinar unto itself. And the reason private equity is interested in palliative care now and in healthcare in general is that the industry smells of money, to use a quote from someone else. For instance, the opioid crisis was caused by the pharma industry malpractice, of course, but it was malpractice that the government allowed to happen by failing to ring-fence the pharma industry. So that's what I mean by corporate capture. The corporations capture regulators in the government. And hedge fund ownership of hospices has become a real problem in the US. Research cited by the Health Affairs Journal in a new study found that for-profit hospice centers are more likely to discharge patients before death, if you can imagine. They just discharge them, sometimes to the street or a hotel room. They're more likely to transfer patients to hospitals and emergency rooms and have higher rates of complaints and deficiencies than the charitable hospices. So what started as a volunteer service less than 50 years ago has grown into a $23 billion industry, accounting for 1/4 of Medicaid spending. So there's blood in the water, so to speak, for investors all over the world. And it's a concern for our palliative care advocacy that we're providing incentives for the sharks to come into the global pool when weak health systems are unable to provide the care people need. For instance, the global palliative care market size is valued now at $5.3 billion, and it's projected to double in the next 10 years. So that's right for private investors, which is not good for poor people. So thank you, and I see the way forward as one of solidarity, faith, and partnerships in what we're doing, even tonight, for instance, and of course, advocacy. So thank you very much. And these are my references.
Thank you for that global overview. And now we're going to go to Miriam Rabner in New York City, who will explain what services are available to New Yorkers. Miriam?
Thank you, Catherine. You said a lot of things that I'm going to cover, but I am speaking for a much more narrow geographical area. First of all, as Michelle introduced me, I'm Miriam Rabner. I want to thank Gray Panthers for hosting me and us. It's a very important topic, palliative care. And I want to give a shout out to Michelle Arnaud, who is an advocate for older adults, of which I am part of. And I could tell you in good hands if we have people advocating and working with us the way Michelle does. In my introduction, you mentioned that I work for MJHS Health System in New York City. We are a not-for-profit organization. It needs to be stressed, just like Catherine just said, there is a lot of hedge funds and corporations and for-profit organizations out there. We were founded over 100 years ago by 4 ladies in Brooklyn who saw a lot of misery, who saw poverty, who saw unaddressed medical needs in the community, and in a compassionate and very low-level way, started to support friends and neighbors. And those of you who have watched television or heard radio commercials in New York area, you might have heard about the Poor Brooklyn Ladies, who started our organization, as I said, over 100 years ago. When I once gave a presentation, somebody asked me, are you one of the original 4? So I want to say I look pretty good for being over 100 years old. We are a large system. We have nursing homes. We have a home care program. We have hospice and palliative care program, and we have even a health plan. What is palliative care? I always get asked, what is palliative care? And I'm going to talk about it a little bit briefly because there are misconceptions out there. Most people, including many doctors, I'm ashamed to say that. I'm the mother of a physician. Many doctors think that palliative care is about end of life. So when I suggest to somebody who has Parkinson's, maybe you might want to have a palliative care consult, they say, no, not now. We're not ready yet. Mom is not ready yet. Oh, do you think I'm dying? It has nothing to do with imminently dying. It is not hospice. It is not end of life. It's a myth, and it prevents patients from accessing an amazing perk. Palliative care is a quality of life benefit for people with a serious and or life-threatening illness. But it offers a dual path, and I want everybody to hear this very clearly. You're allowed to go for a cure of the illness, and at the same time, you can go for best quality of life and symptom management throughout the course of the illness. So it doesn't mean one or the other. That's the difference between hospice and palliative care. You are allowed to have aggressive treatments for your diagnosis, for your illness. In New York State, I'll give you a brief history because the laws are fairly young. In 2010, the Palliative Care Information Act was established, and it was written into law for patients with a terminal illness. That's how it started initially. So they were allowed to discuss, and they were supposed to have a discussion about their prognosis, the range of options for treatments, or the benefits and risks of their options, and the patient's legal right to comprehensive pain and symptom management at end of life. That's how it started in 2010. There were challenges to that law. The law was flawed. What does terminally ill mean exactly? We can't define it. We can be doctors, we can be healthcare professionals. We don't know exactly what that means. Not all doctors feel equipped to have these kinds of conversations with their patients. If you've had a patient or been the primary care physician for 20 years, you don't necessarily want to talk to them and take away, quote unquote, hope or have difficult conversations. That's not the relationship that you're having, and that's not the comfort level of every doctor who is out there. And on the other hand, not all patients want to hear what is happening. Nice horses. So the new law was passed also without sufficient consultation with the physicians, the primary group that will have to implement the law. And if they don't do it, they could be punished for it financially. So there was a very big disconnect between the law being established and what the physicians and other healthcare providers were able and willing to offer their patients. So the Palliative Care Access Act was established shortly thereafter, and it builds on the Palliative Care Information Act, and it expands as follows. It applies not just to physicians, it applies to all healthcare facilities, and it's not just for terminally ill patients, but for all patients with life-limiting or very serious illness. That's a big difference. Having a diagnosis that it's a terminal disease and having a diagnosis for a serious and life-limiting illness. But we know people who have congestive heart failure who can live for many, many years, symptomatic, sometimes, but they're not terminally ill. The palliative care providers must facilitate access to appropriate palliative care and services. That is their obligation. And you know, palliative care was only established in 2007. It's a very young specialty. And not many people, and Catherine said this, not many people are drawn to it. It's not a big moneymaker because the population is very often geriatric. And so after COVID, I spoke to our director of palliative care and Tartania Brown, and she said after COVID, they see an increase in referrals, and they also see an increase in people, doctors, who are willing to go back, some people in their 50s and 40s, doing a fellowship in palliative care because there is a need now, and there's a trend, at least what we see in New York City, to establish themselves. And I worked with a doctor. He was in his 60s, and I said something, and he says, "I'm a fellow." And I'm looking at him. Normally, a fellow is in his 20s. My kid was a fellow. And he said, "Yeah, I was working for 27 years, and I went back to the training, and I'm doing a 2-year fellowship in palliative care so that I can really meet the needs of my patients who are also aging." He's not aging in a vacuum. Palliative care must facilitate access, and it empowers patients to make healthcare choices that are consistent with their personal goals of care. Everybody can have different wishes. One might want to have extend life, even if the quality of life is not optimal. Some people might say, "I don't want the treatment," or "it's religiously or culturally not appropriate for me." That needs to be part of the conversations that palliative care specialists have with the patient, with their caregivers, with their family members, families of choice, biological families, circles of friends for those people who do not have. But it is an individual conversation that allows the patient to express his or her wishes and preferences. And again, patients may pursue palliative care while also pursuing aggressive treatment. Never forget that palliative care does not mean, "Oh, the end is near. Oh, don't say it to mom. She's going to think she's dying." She's not dying yet. So again, what is palliative care? In greater detail, as Catherine said, it's an interdisciplinary model of care for all types of patients with serious or life-threatening illness, regardless of their age, regardless of the stage of their disease. Some people need it at the beginning when they get the diagnosis, or some people only need it 3 years into their diagnosis. If I'm going back to the example of Parkinson, some people are asymptomatic. They still have a life-limiting illness, a serious illness, but the symptoms don't emerge. The hands don't shake yet, or they don't have paralysis in the leg, or they're not wheelchair bound yet. So any time during the trajectory of the illness, it is okay to ask for palliative support. And in any healthcare setting, in any location, in a hospital, in a nursing home, in an outpatient clinic, in a private residence, palliative care is accessible to wherever you live. What does it mean, an interdisciplinary team? It was on one of the slides, but I'm going to review it quickly. It means doctors who are trained in palliative care. Most often it's palliative and hospice care, but it's palliative care. Nurses, dietitians, music therapists at MJHS. We have music and art therapists, the social worker, of course, for everyday needs, for funeral planning, for financial issues, for getting other resources in, and the chaplain. And people often say, "What do I need a chaplain? I don't need a priest. I don't want to go to confession." This has nothing to do with repenting. People who have a serious diagnosis very often have existential despair, or feel it's a punishment, or they have been deserted by their God or by their saints. And it is very helpful for them, and we encourage it, that they have conversations and find solace in those conversations from chaplains who are also trained specifically to address these kinds of issues and to be there. And if not to give necessarily advice, to be sounding boards and to hold the despair or the fears that people are expressing. So palliative care model is appropriate throughout the course of the illness and has the core principles that are the focus on the patient and the family. And family is a large term nowadays. It doesn't just have to be biological family. And very often people we deal with and I support have hired help, but they become like family. They're the caregivers, and they should be listened to, and they should have an input because they know the patient very well, and they observe stuff, and they give the care. So we want their input, and we also want to guide them. It goes both ways. Support for the patient autonomy and respect for all cultural, religious, and individual preferences. Okay, so some people don't make any decisions or don't express preferences without first consulting with their rabbi or looking in their tradition, what are the values about living? What am I allowed, so to speak, within the core tenements of my religion or my belief system? That needs to be taken into account. Shared clinical decision-making is so important. We don't need a paternalistic doctor or a well-meaning doctor or an experienced doctor, either one of those categories or all in one, who makes the decision. The patient and the family members and the caregivers have a voice, and they need to express it, and it is part of the care planning. The goals of care and the plans are made jointly with the palliative care team and the patient and his or her family. And then, of course, the palliative care providers have expertise in the managing of suffering related to clinical, like biomedical, and psychological and spiritual factors, just as Catherine mentioned before. And I'm going to mention some of the clinical issues that crop up very often. Obviously, pain, nausea, shortness of breath in people with congestive heart failure. It's a life-limiting disease, but they're not going to die necessarily. They're entitled to have that addressed. They should have it addressed. Loss of appetite, constipation, itching. There's so many myriad of symptoms that can and should be addressed and can be successfully managed. And on the more spiritual or the more esoteric side is anxiety, stress, isolation, disillusionment, despair, breaking off contact with loved ones, a withdrawal into themselves. That is as important as a manifestation of an illness. And that a good palliative care team will address as well. How to access palliative care? A patient can request a palliative consult through their primary medical provider or a specialist. In the New York City area, most hospitals have palliative care consultation groups, or they can refer to one. But in many areas, and I was surprised how close to New York City, and especially in rural areas, they aren't so prevalent. They're not always so functioning. They're not even part of some of the rural hospitals. So it is beneficial, of course, if you are in a metropolitan area. But what's most important is that many doctors do not refer to palliative care. There is this hesitancy, again, because there's a myth that it means they are condemning somebody to death, or maybe they want to not take away the hope, or if you're very cynical, they don't want to share the billing with other people. There are doctors and there are doctors. And so the most important thing is for each one of us and everybody whom we know and whom we love to self-advocate, to be literate about what's out there, to be educated. And that's what I do. I go out into communities and I talk about what is out there, because if you don't know what you don't know, you're not going to ask for it. So it's very important to self-advocate. And where ageism creeps in, I made myself a note here. I've encountered it so many times. Oh, I'm already 87. I'm too old and I should just write it out. No, there is no need. That's internalized ageism. Nobody is too old to access the proper support that they are entitled to. And we should not tolerate if people in the healthcare settings that we go to talk to us in baby talk because we have gray hair or because we're very hard of hearing, and they think, oh, she doesn't get what I'm saying. No, no, no. Don't talk down to me. Don't talk baby talk to me. And don't think that I'm too old and I don't have a voice and I don't have a mind and I don't have preferences. I'm the boss of myself. And now is the time that it's not selfish, that is just what we are entitled to, and that is part of the dignity that we bring to any encounter and that we want to have respected. Palliative care consults are billed the same way as any specialist level visit. Most insurances cover it, but possibly with a copay. So if you want to access it and not have a bill that all of a sudden shows up, and I don't even know when I saw this person, find out from your insurance company if it is covered. We don't know of a list of all the healthcare insurance companies that have it, but you can call up and you can ask. Medicare does cover it, and Medicare, it is for older people, 65 and over, expanded the telemedicine coverage at the end of 2024 for 3 months. We wanted more. The lobbyists wanted more, but it's been expanded for 3 months, which fills the gap for those people who cannot access palliative care in person, especially if you have an illness that prevents you from moving freely, for example, or if you live far away or it's bitter cold like it is right now in New York City. It's wonderful to be able to have a telehealth consult with a palliative care group or specialist so that you don't have to leave your home. Palliative care physicians consult and support the PCP and the specialist, and the scripts and the medications are written by that PCP, by the primary care physician, or by the specialist. Palliative care consults, but it doesn't hand out the medicine. But what it does do, it holds together all the different doctors that a patient might see and coordinates the care among the different specialties so that everybody is informed, everybody knows this patient is on this medicine, so don't prescribe something else when they see you that might interact. And it is really a hub position that holds it together and is managing the overall care for the patient. Palliative care can be accessed at the beginning of a diagnosis or any time during the trajectory of an illness, we said. And most of the time, after a few months or a few consults, people can go off. Symptoms are being managed, pain is being managed. That doesn't mean that 6 months from now, if you have Parkinson's or you have congestive heart failure, that you might not need a new consult because your condition has changed. So you can come back on, and there is no conflict. There is no limits to how many sessions you can have. And the problems will be addressed and new symptoms as they arise. Eventually, palliative care and the trajectory of an illness, if it follows its natural course, will lead to a decline in the patient. And then there is a conversation that needs to be had with the patient and the family and the caregiver circle, and maybe the specialist, whoever is taking care of that patient, whether treatment should be pursued or treatment is now maybe even harmful or is just not allowing for quality of life. And that conversation will then bring up the topic of hospice care and the end of treatment. And that will be a different presentation that I will give to Gray Panthers, and it will be focused exclusively on hospice. And in the meantime, I wish all of you the best of health. Thank you.
Thank you, Miriam, for that very comprehensive description of what palliative care is, and it's about quality of life. And our tech manager, Emily Trask, is going to say a few words about her experience as a family member with palliative care. So Emily, would you like to close the program?
Thank you, Michelle, and thanks for the opportunity to share my family's experience with palliative care and how it's starting to help us navigate our loved ones' complex medical journey. And I hope that it can shed some light on how, this can help others. And so I've been helping care for an older family member who is a Vietnam veteran, and he's faced significant medical challenges. Over the last few years, they've dealt with a hip fracture that never healed properly, renal failure requiring peritoneal dialysis, cardiac issues managed with a pacemaker, and skin cancers on the lower legs, the last three attributed to Agent Orange exposure. So they're now 100% service connected through the Veterans Administration VA hospital system, meaning that nearly all of healthcare services are provided by or paid for by the VA. Each of the conditions alone would be difficult to manage, but together they've created a maze of primary care appointments, specialist visits, tests, blood work, imaging, and mountains of paperwork, and many sleepless nights. The VA has been great, and I count us lucky. But despite that, and also having a very strong family support system, it often feels like we're drowning, juggling schedules, shuttling between different providers, managing transportation, trying to understand the purpose of each appointment. There's no communication between the many teams involved in their care and us. At times it felt as though their medical needs were being addressed in silos. No one was looking at the whole person and the toll that all of this was taking on them and on us. But recently, while trying to pursue a full hip replacement for my family member, which is complicated because of dialysis and other conditions, we were referred to palliative care. And initially, we did not understand what palliative care was. A friend who works in the VA system had suggested it months earlier, but we hesitated because we mistakenly associated it with hospice. And for us, that did not feel like the right fit at this time, and for my family members' situation, goals, and needs. Meeting with the palliative care team as part of this pre-operative process seemed to be a turning point. We met with the palliative care physician, a nurse case manager, and it was very different than any appointments that we've experienced before. We spent an entire hour with them, an unheard of luxury in today's fast-paced medical environment in the US. They listened to every detail about my family members' medical needs, mental health, and support system. They wanted to know about their life, what they did before retirement, their family, their experience in Vietnam, who they were and are beyond their diagnoses. They also acknowledged and validated the role of caregivers, mentioning more than once that they were there to support all of us. And for the first time, it felt like someone was looking at the full picture, coordinating care, and ensuring that my family members' voice and their wishes were at the center of the conversation. I think we all breathed a collective sigh of relief. And since that meeting, progress has been slow, but it's progress. And it feels like we finally have a team in place to help us navigate and coordinate care. And it wasn't till, recently in this experience that I realized just how serious and ageist the system is, because I've seen firsthand how my family members' agency in their own care has been stripped away in many cases. Too often during appointments, doctors speak to me instead of them. Really, I felt ignoring concerns and assuming they can't fully participate in decisions about their health. Um, which it robs adults of their dignity and autonomy. And palliative care, in our experience, really was a stark contrast to this. And it reminded us that compassionate, person-centered care is possible beyond managing symptoms and diagnoses. It's about restoring humanity to a process that often feels dehumanizing. Thank you.
Thank you, Emily, for sharing that personal story. And thank you to Catherine and Miriam for defining a very misunderstood term. I hope this has really been helpful for everybody. And we're at the 3:00 end of our program. Thank you also, Catherine and Miriam, for suggesting future programs that we'll have to set up. So we look forward to seeing everyone again on February 25th, when we're going to have a very different program with Jack York, who's co-founder of Never Too Late and chief storyteller of Tailgate. And he will express his passion about improving quality of life for older people. So that's next month. Thank you to everybody, and see you then.
Bye. Thank you,
Bye-bye.
Michelle, and everyone.
Thank you.
Thank you.
Thanks, Emily.
Thank you.
Hey,